Good evening, Dr. Udedar and Pankaj Maheshwari.
Good evening.
Good evening,
Some
Good
sir.
evening.
Yes, Hiren is right. Some technical problem was there.
No
Okay.
problems.
वाली टी शर्ट आपको पता नहीं है ना पांडा वाली टी शर्ट क्या बोलेगा ब्लू वाला पांडा वाली टी शर्ट ब्लू पांडा टी शर्ट
मत तो सुना ना दागा तो टेढ़ा हो गया मुझे सूख के
तेरा नाम वाला पापा वाह 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 वाह
पढ़ाई करो बेटा सिस्टर को बोलो अच्छे से पढ़ेगा सर प्रॉमिस किया वेरी गुड बॉय
Recording in progress.
Who is answering today? Paras, you are ready?
Please make Paras the host also because he has to share the PPT.
Paras, you cannot start.
So today Dr. Asha and Dr. Paras are going to answer.
Ashay.
Yes, Dr. Ashay Patel from JJ Hospital and Dr. Paras.
Paras, you can't start your presentation?
So starting, sorry, connecting.
Anyway, Ashay,
Dr. Ashay is just joining. 1 minute.
meanwhile, Ashay,
Dr. Ashay has joined. Please make
yeah,
him
yeah.
the host and unmute him.
Hello.
Yes, Dr. Ashay, we can hear you.
Fine. So, Maheshwari ji, Balaji, Gite sir, so we start the clinic now.
Yes, sir.
Okay, Ashay.
Yes,
Now you
sir.
know how to go about. Name the instrument, correct? Then the material from which it is made. Third thing will be you will talk how to sterilize it, how to clean it, sterilize it, and then what are the uses, right? What are the variations, everything. Come on.
Hello.
Yeah, Ashay, you start.
Yes. Yeah. Yes, sir.
So which is this? Which
So,
is this instrument?
sir, this is a nephroscope along with its sheath, and sir, it is made up of stainless steel and sterilized by autoclave, and it is a rigid instrument. And the parts are sheath and telescope. Sheath and telescope, and it is available in various sizes, and predominantly uh, two major companies are Karl Stores and Richard Wolf. And standard universal nephroscope is of 24 French. And it is used in percutaneous nephrolithotomy, sir. And the mechanism is it uses a rod length system for imaging, and the scope has an eyepiece, and eyepiece working channel in the shaft. Yes, sir.
Sure. Paras, can you now describe this, the whole thing?
Sir, this is a nephroscope with its sheath. Uh, so it is having a eyepiece with a parallel offset optic system. It is having an instrument channel, a light pillar for light source, a shaft with a instrument. With a irrigation inlet, and there is also a outer sheath with a uh, outlet. So it is made up of stainless steel. It can be sterilized using autoclave, ETO, or plasma sterilization also by 2% glutaraldehyde. It is used in case of percutaneous nephrolithotripsy, or it can be used in case of bladder stone also. It can be perurethral or PCCL also.
Okay. So what is the size?
So they are available in different sizes. The standard size for nephroscope is around 24. Below 20 is a mini PCN, mini perk.
हाँ अच्छा ठीक है ओके ओके जिससे आईवी में आउट है तो मछली वो रहेगा
Gite sir.
He has majoritarily covered the point, but haphazardly covered. Just his identification of the scope is a nephroscope. Then second is he should have tell a classification that is depending upon the make and depending upon the size of the nephroscope. It will include everything, that is Karstose, Richard Wolf, and Olympus. Major difference between the Karstose and Richard Wolf, the all Wolf nephroscope are usually integrated. तो separate ऐसा सीट Wolf के इसमें नहीं रहता है. जहाँ पे भी सेपरेट सीट एसोसिएट रहता है वो इधर स्टार्स का या फिर ओलंपस का रहता है. तो दैट इज वन ऑफ द आइडेंटिफिकेशन मार्क. देन पार्ट्स ऑफ द नेफ्रोस्कोप, थर्ड पॉइंट इज सीट एंड जो एक एक जो आईपीस है उसके बाद में वो ऑब्लिक एंगल का है, स्ट्रेट है, इंटीग्रेटेड है, नॉट इंटीग्रेटेड है. देन ये सब चीजें बताना पड़ेंगी. देन यूनिवर्सल नेफ्रोस्कोप का साइज ऑलरेडी उसने बताया है सर. देन दूसरा जो है वो क्लासिफिकेशन के इसमें फिर मिनी पर्क मतलब ऑलरेडी 20 फ्रेंच का उसने बताया, लेकिन माइक्रो पर्क, अल्ट्रा मिनी पर्क ये सब चीजें का भी उसने बताना चाहिए था साइज. तो इट विल एंड यूजेस ऑलरेडी उसने बताया है. तो ये सब चीजें जो बची है वो मैंने कवर कर दिया. अल्ट्रा मिनी अगर है तो 3.5 फ्रेंच का टेलीस्कोप रहता है एंड 6 फ्रेंच का सीट रहता है. एंड जो निडल स्कोप है वो 4.85 फ्रेंच का रहता है निडल स्कोप.
So Ashay, why there is a sheath? What is an advantage? And what is the disadvantage? Paras.
So it makes the system continuous. So there is a inlet and there is a outlet. So it reduces the pressure, intrapelvic pressure.
So you can apply the
Disadvantage is
suction.
it increases the size of the.
Yeah. So the
Nephroscope.
disadvantage, it increases the size. The advantage is that the chances to the trauma or the thing injury to the telescope is less when you are using the sheath. Okay. And second thing is, as you said, outlet and inlet channel. But most important thing is that if you are not using this outer sheath, then the water irrigation and the instrument channel is the same. So whenever you put the instrument, then automatically the irrigation decreases and the vision may get obscured. So that is another advantage of this outer sheath, and it makes it more sturdy. Okay, so these are the advantages. Increases the uh, visibility, and by proper irrigation makes it more sturdy. And third is outlet and inlet channel. Okay, so can one of you tell us what are the steps of PCNL?
The steps of PCNL start with the preoperative planning by reviewing the radiological images and making a operative plan. Then under anesthesia, either general or spinal, the patient will be induced, and then a ureteric catheter will be inserted through
So
cystoscopy.
first of all, which anesthesia you prefer?
Sir, general anesthesia is preferred because we can control the respiration and give breaths and stabilize the kidneys during puncture. So general
And what are the
anesthesia will be
different types
preferred.
of PCNL?
Sir, supine PCNL, prone PCNL.
So which PCNL
Generally,
you?
prone PCNL is done. In my institution, generally, prone PCNL is done, sir.
So you say that in our institute we normally we do prone PCNL, and most of the cases or all the cases we are doing under general anesthesia, but it can also be done in spinal anesthesia. But when you will prefer, even if you are doing spinal anesthesia, which are the cases you will prefer to give general anesthesia? Ashay?
Uh, Sir, like stag on calculi, when operative time is more than expected, then I would prefer general anesthesia.
Yeah, because it is very difficult for a patient to lie down in a prone position for a longer period of time because his chest is always going to be compressed. Okay,
Yes, sir.
that is number one. Number two, you might have to go through 11th and 12th rib or little higher
Yes, sir. Yes, sir.
incision so that after some time the spinal start wearing down. And when you are doing that, patient may have a pain.
Okay.
Correct? So
Yes, sir.
these are the two main reasons you like to give
General anesthesia.
general anesthesia. And same way, when the kidney is very highly spaced place and you want to puncture the upper calyx.
Okay.
So there is another case where you like to give general anesthesia even if you are regularly doing in spinal anesthesia. Fine. Go ahead.
Sir, then in the supine frog leg position, I would like to do
No,
cystoscopy and
first of all, you like
insert.
to do cystoscopy or not?
Yes, sir. Cystoscopy and ureteric catheter insertion.
So you have to say, so how will you prepare your trolley? What are the things? Tell me from first to end. What are the things you will keep it on your trolley?
Uh, uh, Sir, in the trolley, I would like to have uh, uh, 17 French cystoscope with sheath and one 0.035-inch Teromo guide wire, one 6 French ureteric catheter, and then I would like to have initial puncture needles, two. Then I would like to have uh, wire is already there. Then, uh,
Yeah, you have done PCNL or
sir,
not?
yes, sir. Facial dilators from 6 French to 16 French. Uh, then I would like to have the Amplatz dilator set and also uh, this the central rod and the telescopic metal dilators and various Amplatz sheets and nephroscope and uh, probably
Yeah, tell me.
gauze and
Litho class, you
yes,
want
sir,
a litho class or laser,
lithoclast trolley, yes, sir.
or you want a laser, then irrigation fluid,
Yes, yes, yes.
telescope, or just saying camera, Siam. You're not going to
Cameras,
keep all this ready?
yes, sir. Everything, all this.
See, when examiner asks you, he just wants to know if you are doing it regularly or assessing regularly and you're arranging all these things, these are the things which are required. Which knife you are using?
Sir, 11 number.
11 number. What precaution you take? You use 11 number knife. What precaution you take?
Uh,
Will you like to?
Tie with thread.
Yes. Why?
tie with thread so that it does not go inside. It is not lost in the field.
Yeah. So there are cases where we have initially when we used to do it, make it little more, because if there is too much of fibrosis, try to make a little deeper incision, and then we have lost it into the body, and then becomes very difficult. Fine. Okay. Now come on. Tell me the steps.
Sir, once I put the ureteric catheter, I will check that on the on fluoroscopy, and then change the patient's position to to prone.
What
Then
you will do to ureteric catheter?
yes, sir.
What you will do to ureteric catheter?
Sir, I will tie it to the Polish catheter so that it does not come out.
And
Tie it with silk thread,
and what else?
and then wrap it in a towel so that it does not touch while changing the position.
So sterile isolation. Say like
Sterile isolation. I will
okay.
do the sterile.
Then
Change the patient's position to
so when
prone.
you are changing the position of a patient, what precaution you will take?
So to make sure that the ureteric catheter is not pulled out.
Yes.
Uh,
Yes. Not only pulled out, even the Foley's catheter is not pulled, because now you have tied it to the Foley's catheter. So if by chance Foley's catheter is little pulled out, with that the ureteric catheter will get pulled out. Okay,
okay.
fine. Now you are given the prone position. Will you like to put a
Position,
bolster or anything?
uh, sir, it is generally not preferred in my institution.
Okay. Then
Yeah.
what
I would
else?
like to prepare the parts,
Mm.
do the
You
fluoroscopy
put any
and
sandbag?
RGP.
Do you put any
Uh,
sandbag?
no, sir, cotton padding just for
Okay.
the position.
Okay, fine. Go ahead. Now,
And then I will prepare the parts and do the fluoroscopy and retrograde pylography, and then uh, visualize the anatomy, and then go for the puncture with the IP needle. And so, according to the stone, puncture will be taken. It should be the shortest part to clear the whole stone. And after taking puncture, we will, if water comes, then we will pass the guide wire into the system, and then increase the incision through the blade while the IP needle is in situ, and then remove the IP, exchange and remove the IP needle. And then we will insert the facial dilator serially from 6 to 10 French, and then insert the Alchem central rod, and go ahead with the telescopic metal dilatation until the desired generally 24 French, and then insert the corresponding amplas sheath, and then go ahead with the nephroscopy and visualize the stone, fragment the stone either using laser or pneumatic lithotripsy, then remove the stone fragments, and after ensuring complete clearance, uh, then through fluoroscopy and through nephroscopy, then I will go ahead with antigrade degescenting, and then insert a file and confirm that on fluoroscopy as well. Then before that, I will remove the ureteric catheter, and then after the antigrade degescenting is done, I will insert a corresponding nephrostomy tube, fix it, and clamp it, and do the dressing, and change the position back to supine, and a patient can be extubated.
mm. Paras,
And Foley's will
what
be
are the
continued.
mistakes he has done?
Right procedure. It's a right.
Hmm?
Mostly it's right.
Most of the steps are right.
Yes.
Okay. So what are the problems? Just tell us at every point what are the problems you will incur and how will you tackle it? So
So
first, what is the
starting with
yeah
cystoscopy.
yeah tell us.
So starting with cystoscopy, sir, we would like to see the urethra. If it is having any stricture, we can do a VIU, uh, or there can be difficulty in ureteric cannulation also. Uh, so we can use a L-Bram lever, or we can just bend the ureteric catheter also. Uh, then, sir, in change, we'll fix the ureteric catheter to the Foley and keep it sterile. Then during the change of position, at least 3 or 4 person to be available. Uh, Head and leg, and the especially the upper limb of the patient should be dealt with great precaution. It should not be abducted. It should be placed after proper rotation of the arm. Uh, uh, in case of the puncture, sir, we will.
Where Paras, tell me which if the stone is on the right side when you are doing procedure from the beginning, where you will put the siam and where you will keep the trolley and where you will keep the irrigation.
Sir,
Left
Siam
sided. Hmm.
left.
Left sided calculus is that you are going to do left sided PCNL. Where you will keep, on which side of the patient you will keep the siam and which side you will put the.
The patient's right hand side will be the Siam. The trolley will also be on the right hand side. The irrigation can be kept between the legs, or towards the surgeon.
Hmm. So left
Towards the
side you are
surgeon,
going to do. So siam will be on the right side. So when you make it a prone, the right side will come on the siam side.
the patient's right hand, sir.
So in supine position, patient's right side, you are going to keep siam.
No, sir. Left.
It is
When
always
patient
on
is
the same
supine,
side of
yes,
the patient.
same side. Yes, sir.
If you are going to do prone prone PCNL, always keep it on the same side of the patient. Because you are going to turn the patient, na? Paras, understood? Hello?
Yes, sir.
Yes, sir.
Yeah. And normally, where you like to keep the siam imaging system? The best is to keep it at the head side so that whether you're doing upper puncture or lower puncture, you can always see it. Otherwise, the siam will come in your way. But nowadays, you are getting mobile TVs. So you can, keep it wherever you want. Fine. Okay. Now tell me what are the problems you come across when you are doing the puncture? And what are the different types of puncture? Maheshwari ji.
Yes, sir, I am there.
Now you can teach them about your punctures, your written papers also on that, an article also.
Yes. Kindly describe so that we can take it
Yeah,
forward.
yeah, describe. So what are the Paras, what are the different ways you can do it? Puncture, okay? And normally how you do it?
Sir, there is a bullseye technique and a triangulation technique, sir. Or we can, there's fluoroscopic guided, or we can do by a sonography guided, or puncture. So in the fluoroscopy guided, there is a bullseye technique or a triangulation technique. In the bullseye technique, the C-arm is rotated to 30 degree so that it is in line with the needle, and we directly puncture the stone. Uh, and in the triangulation technique, first the C-arm is 0 degree, then we puncture, then we turn the C-arm to the 30 degree to see the third dimension of the depth, and then we progress the needle. In sonography, we use sonography to puncture.
In sonography, how you do it?
So we will localize the calyx using a sonography, and then we'll punch.
And then?
We will puncture the calyx, that calyx particular.
So after that, what you do?
So then we will instill dye and see in the fluoroscopy or we can directly put the glide wire also.
Okay, so when you put a glide wire in, then you'll do the fluoroscopy and see.
So if fluoroscopy is not available, if fluoroscopy is available, then we'll put the dye and we'll see if the desired calyx is punctured or not. If the desired calyx is not punctured, then under fluoroscopy, then we can puncture.
Okay. Fine. So what is the triangular method you describe?
So first we will keep the C-arm at 0 degree. Then we will puncture until we can see the movement of the kidney. Then we will turn to the 30 degree for a better assessment of the depth, and then we will further progress the IP needle to reach the desired calyx.
So then the way you have described, what's the difference between your bullseye and triangulation? Both look same. In bullseye also you rotate the C-arm towards yourself and then puncture. In triangulation also you have done the same thing.
So in the bullseye, we just go in one direction. But in triangulations, we first keep at 0 degree. We go to the particular depth where the kidney is uh, moving with the needle, and then we on 0 degree, then we see for the depth for the puncture.
You see, in your description there were few small errors. You even in bullseye you don't aim for the stone. You always aim for the calyx. Okay, never say that it will be a stone guided puncture. So in bullseye, what you do is, so you will take the head of the C-arm towards you till the calyx, which was seen like this, starts being seen head on. So the calyx should look like a small dot. Now hold the needle in the line of the C-arm so that even the needle looks like a dot. So now both are aligned, and then you gradually enter in this direction. So the advantage of bullseye is that it is an easier puncture to do. The disadvantage is that the puncture is usually not aligned to the infundibulum. Because it is not aligned to the infundibulum, when you enter from the calyx and try to go into the renal pelvis, there may be some torque on the kidney which can probably increase the risk of bleeding. So theoretically, the risk of bleeding is higher in bullseye as compared to triangulation. And as you rightly said, in triangulation, you take assessment of the angle and the depth. So the 0 degree gives you the direction and 30 degree gives you the angle and the depth. Again, if we have to describe this further, there is one technique which Dr. S.K. Pal describes as a gradual descent technique, wherein you make a puncture away from the calyx, and by rotating the C-arm to and fro, you decide the direction and depth and gradually move towards the kidney. Then there is also a ultrasound, endoscopy guided puncture, where you would put the a flexible scope in the desired calyx, and then under the vision of flexible scopy and fluoroscopy or ultrasound, you will make a puncture. The advantage of using endoscopy for guidance of puncture is that the risk of overshoot will not happen, and it is easier to keep a through and through guide wire through the ureteroscope. So the ureteroscope will be just held in that calyx. The ureteroscope will see that the needle comes directly through the center of papilla, and your dilators will be just till the papilla or just inside, and there will be no risk of overshoot. So these will be various. Now, when you describe the ultrasound guided puncture, what you should say is that I would hold the ultrasound on patient's back and then gradually come laterally downwards. So the first fluid filled cavity that I would see would be the dilated posterior calyx, and that is what you should aim for. Again, when you do ultrasound guided puncture, it is important that if there is a ultrasound, if there is a puncture guide, then using the puncture guide to puncture the calyx would be easier. Once you have punctured it, if you want, you can use now fluoroscopy, put in contrast, confirm that you are well positioned, place wire and go ahead. A lot of Japanese and Chinese researchers don't use fluoroscopy at all. They do the complete puncture by sonography. So they would put the needle. Once they have put the needle, if you get a good efflux from fluid efflux, then you are well positioned. Then you remember the direction and angle, and rest of the dilatation you do based on that direction, angle, and the distance that you need to go in. This is just for you to know. This is not something you will describe in the exam, because again, this is a more risky way of puncture. The only advantage is fluoroscopy is avoided, but you need an immense amount of experience for such type of puncture.
Because in ultrasonography you cannot judge whether you are doing overshooting or lots of things and angles and other things. So as Dr. Pankaj Maheshwari has said, you really require skill to do that procedure. Fine. So what are the complications?
Sir, before we go there, how
Ah.
will you decide how much tract size to make? What is the deciding factor for the size of tract?
Ashray,
The size of the calculus.
No, that's not
no,
right.
that is secondary. You may you may think of doing a mini perk, or you want to do normal PCNL. That is different thing. But what he is saying that how much dilatation you will do.
See, the deciding factor for the dilatation is your size of infundibulum. Okay. If the infundibulum is very narrow, then irrespective of the stone side, you will not over dilate because the risk of trauma to the infundibulum increases. So your tract size should be the size of infundibulum or probably smaller than that. Okay. The dilatation should only be till the calyx, and beyond that, everything will be under vision. Okay. What are the pros? What are the different modes of dilatation? One, you have said alkanes, and second, you said implants. Any other modes of dilatation?
So balloon dilatation is also.
So, what are the pros and cons of all three modes of dilatation?
So in Alchem's telescopic serial dilators, the advantage is that the tract is maintained. There is a tamponade effect, which is also maintained, sir. In case of Amplatz serial dilator, every time we have to remove the dilator, so the tract can be missed. The tamponade effect is also lost. The advantage of Amplatz dilator is that it is having less chance of PCS perforation or over dilatation. In case of balloon dilator, it is a single step dilator with a Amplatz which is preloaded over the balloon dilator. It causes a single dilatation gradually, and it maintain tamponade also.
So, very well said. So, what do you mean by preloaded implant sheath? Can you explain that?
So in the balloon dilator, proximal to the balloon, the implant is preloaded, so that just after dilatation you can place the implant.
Right. So the
So the
balloon
tract is
should
not.
go through the implant sheath.
Yeah.
So you will put an initial puncture needle, you will put the wire. Now, when you put the balloon dilator, before that, put the implant sheath, put the wire through the implant sheath. Put the balloon through the implant sheath, and then put the balloon inside. Now, the one major advantage of Elkin's dilator is because it is metallic. You can sterilize it, you can reuse it. Theoretically, implant dilator is a single-use dilator. One you have said about the tamponade and risk of bleeding. One disadvantage of implant dilator is that tip of the implant dilators is conical. So you need to have adequate space in the calyx for implant dilatation. If the stone is tightly fitting in the calyx, then your tip, when the tip of the implant dilator is inside, the terminal few millimeters will not get dilated. So your implant sheath will remain outside. So for a proper implant dilatation, you need adequate space in the calyx. And the advantage of Elkin dilator would be that in patients who have been previously operated, or if the tissues are tough, it is easier to dilate that way. So Elkins is reusable, continuous tamponade, possible in difficult situations like previous surgeries. Disadvantage is trauma, overshoot, bleeding. Implant dilators are easier to use, single use, but need space in the calyx. And balloon dilator, the advantage is it's a single step dilatation, but disadvantage would be the cost.
Fine. So now tell us the complication of the puncture. Akshay.
Complication will be failure of puncture first. That means we are not able to aspirate urine. We are not in the system. And then bleeding. If the IP needle goes into a blood vessel, if it is too close to the hilum, then
Yeah.
yes,
Injury to the surrounding structure.
injury to the surrounding structure. Yes.
Okay.
Colon and
Yeah. Now, during dilatation, what are the difficulties and what can happen?
Under dilatation,
Okay.
that means we have
Under
not reached the
dilatation,
calyx.
over dilatation,
dilatation,
then
TCS perforation, that is also over dilatation. Then bleeding.
Then during dilatation, if you apply the force, the guide wire may bend and you
Kinking of guide.
yes, so kinking of
breakage of
guide,
guide.
and instead of entering into the pelvic vessel system, you are outside. Okay.
Yes, sir.
Now, how will you confirm every time when you are doing the dilatation? What is the trick that you want to see that it is you are not bending the guide wire and you are sliding it properly?
Sir, we do it under fluoroscopic guidance and make sure that the path is a short straight line up to the calyx.
On CM, it is a two
There is no
dimensional. Now
kinking of the guide wire.
you think that your dilator has properly gone into the pelvic LSL system. Okay. And you want to see that it is not king, your guide wire. How will you confirm?
Sir, we can pull it a little bit and see if it
so
is
it should be gliding. The guide wire
gliding.
should glide very easily in your dilator. So that is what you keep on doing. When you are inserting it, every time you put it, slide it more, just see that glide wire is moving. It is sliding properly, easily. That means you are dilating properly over the guide wire and you are not kinking it. Okay,
Yes, sir.
fine.
So, you
So
know,
now,
this has
as
been described by Dr. Vasudev Ridorkar and he has called it as a friction test. So if your wire moves freely within your dilator or guide rod, then your angle and direction is well maintained. But if the movement is difficult, then probably there is a kink or you have changed the angle of your dilatation.
friction test, just remember.
Yes, sir.
Fine. So now you're dilated, then now what you'll do? You will do the metal dilatation. And you'll put the, how will you? So what energy normally you are using?
We can use a pneumolithotripter or a laser.
So when, Paras, when you do mini PCNL and when you do regular PCNL,
So,
yeah, tell me now.
so it
Which size? So come on, till what size you like to do mini PCNL and when you will do regular PCNL? Asha, you can answer.
Sir, in children, we will prefer mini PCNL.
Okay. And in adults? So normally, it's very simple question. Till which size in your institute you are doing RIRS?
2 centimeter.
2 centimeter. So about 2 centimeter you like to do regular PCNL or mini PCNL?
Mini PCNL.
Till what size?
Particular size तो sir ऐसा
Right? Normally till what size you will prefer mini PCNL? And after that you will say no. Which size you will say no, in this case I will not. Like a stagon. So in stagon you will not like to do mini PCNL, but in stagon, if you have to make an extra puncture and the stone is not big, better to do mini PCNL. So there may be a combination. In stagon, you may have a combination of multiple system. You may have flexible, you may have supine PCNL with the uroturinoscopy, multiple things. So if it is stagon or more than 3.5, I prefer centimeter, I prefer regular, so that big pieces can be removed easily. In mini PCNL, it will take a very long time. Maheshwari ji, what is your say on this?
I agree with you, sir. The decision about the tract size will be based on the size of the infundibulum and the size of the stone. If the stone bulk is very high, then it is probably better to make a larger tract so that you can pick up larger pieces. So a cutoff of around 3 centimeters can be taken.
Correct. Now, Akshay, tell us when you're doing PCNL, which are the, like you have got the stagon calculus, then which are the different ways you can remove all the stones?
Sir, if we have to make a single puncture, then upper bowl puncture is preferred for a stagon calculus. But we can make multiple punctures, multiple dilatations to facilitate
So
complete clearance of the stagon.
number one, if it is a stagon calculus, and if you cannot remove from one tract, you may do multiple punctures, and it may be a normal tract or it may be a mini PCNL. Correct? So that is number one. Number two, You're done. PCNL. And now there are two small stones remaining.
Sir, a flexible nephroscopy will be done to ensure complete clearance
Yeah. So the second method
before
is
the
you may use.
end of the procedure.
Yeah. Okay. Now from the beginning, you know that there are multiple small stones, but each stone is like 7 to 8 millimeter in the different calyx, and there is a one big stone about 2 centimeter. Now what procedure you will select? Paras. Asha, you also don't know?
Sir, I would like to go ahead with PCNL, and then through flexible scope, I would like to bring those small stones to the pelvis and then evacuate.
Any other
So
way?
we
Flexible
can
scope
sir,
from where?
puncture the particular calyx in which the stone is left. If it is small, we can just instill saline through the IP needle and uh, push the stone to the
So you can
pelvis.
flush. If it is a
Flush
small
the.
stone, you can flush the stones. Okay, fine. Without making actual dilatation. Correct? Just put a needle and flush it up. Okay. But from the beginning, can you plan out something?
So we can do multiple puncture if needed from starting upper calyx or lower according to the stone.
What about RIRS with supine PCNL?
ECRIS can also be done.
Yeah.
So
So
we
it is
can
called.
fragment the stone there using RIRS, and in the supine PCNL we can suction it off from the PCNL side.
Yeah. So many people they just hold the with the basket, they hold the stone and bring it into the pelvis. And with the PCNL, you can either remove it or you can break it. Much faster procedure. Anything
So
else is there?
if you want to answer this question as to how to improve the stone-free rate in Stefan stone, you should start by saying that I would choose the calyx which gives me the maximum access. Usually the upper calyx will have an advantage because upper calyx will give me access to the upper calyx, renal pelvis, lower calyx and upper ureter. Then if there are larger stones in the peripheral calyces, I may pre-place the wire so that if necessary they can be dilated. If there are smaller stones, I can flush those into the pelvic system. I can use a flexible nephroscope, but a flexible nephroscope will need two things. One, that the tract size will need to be at least 16 French and above. And two, there should be enough space in the renal pelvis for the scope to bend. You see, flexible nephroscope needs adequately dilated system. And the last option will be ECIRS. You see, in ECIRS, the flexible scope is used only to reposition the stone. You usually don't like to break the stone by flexible scopy. So it is called as passing the ball. So by the with a Dormier basket, you get the stone out of the calyx, get it into where your ampla sheath is, so that by nephroscopy you can remove it. And then if there is still residue, then those can be used by, you could even use ESWL at the end after PCNL for residual stones.
Yeah.
What is maxi PCNL? So you all know, you have spoken about mini PCNL. What is maxi PCNL?
Paras, answer.
Maxi PCNL.
Okay, this is just a novel name for No, maxi-piscinal is when the tract is 30 French and above. Okay, so
See, you
that is advocated only for very large staghorn stones.
normally earlier we never had such a other scope, so we used to dilate up to 32 French only, and then put the very large implants. If you see now, you will be so much afraid to use. Correct, Maheshwari?
True,
Huh?
sir. True, sir.
Now when I look
So,
at my ancient instruments, you know, I really wonder. 12 French,
so
12.5 French ureterinoscope, and then 32 implants. It was really horrifying that time, and
So
quite a
it
lot
was
of
inner
bleeding.
diameter 30 French and outer diameter was maybe 34 French.
Yeah.
When the PCNL initially started, they made a 40 French tract, and gradually from 40 they have now come down to a micro PCNL. What is the difference between mini and ultra mini PCNL?
So mini PCNL is any PCNL between 15 to 20 French. And below it is ultra mini.
सर ये 15 फिगर थोड़ा करेक्ट नहीं है, कहीं पढ़ा है आपने 15 फ्रेंच?
Below any 20 French is mini P.
नहीं तो what is the lower limit of, so if it is a 8 French, then what will it be called?
Mini micro.
Ultra mini is having a 7.5 French scope with 11 outer sheaths.
So 14 to 20 is mini PCNL, and usually say less than 14 is ultra mini PCNL. Then there is micro PCNL, which is through the needle, and there is a micro mini PCNL where there is around a 7, I think 6.5 or 7 French tract. You will need to confirm this.
7.5.
Yes, you need to confirm this. What is the place for micro PCNL? Where will you use micro PCNL?
For a small stone, especially in lower calyx.
So the advantage of micro-PCNL is that the tract is very, very small. The disadvantage is that because the irrigation is low, the vision is poor, and there is no way you can pick up the fragments. So any stone where you just want to go in dust and let the stone come out spontaneously, that is the stone where you would use a micro-PCNL. One more disadvantage of micro-PCNL is going from one calyx to other is practically not possible. So you have to be precise in the calyx where the stone is, see the stone, dust it with laser, and just remove the needle, and that's the end of the procedure. You will not be able to place a stent, you will not be able to remove fragments, you will not be able to go from one calyx to other.
Fine. So now tell us, what are the complications?
So complication can be, there can be an acute hemorrhage, there can be a delayed hemorrhage, there can be injury to
Start with
the
the procedure, beta. Always that failure of the procedure, failure of puncture, failure of dilatation. I know, as you said, all everything under dilatation, over dilatation, like that. You start with that, then bleeding, then injury to the other organs. So this is during the surgery. So if you have done under dilatation, what you do in your institute? Paras?
so we try to keep the glide wire in position, and we follow the glide wire. We can dilate the tract using the stone forceps and guide through along
The
the guide.
best thing is what? Under vision, you put at least the guide rod. If you are using the normal, okay, under vision and normal scope, then under vision, you put the guide rod. Or you remove the, if you are doing mini PCNL or something, you again, uh, over the guide wire, you dilate little more. Or you put the implants little more inside.
You should never say in exam that you will dilate with a forceps. Okay,
Yeah.
that is something you may have seen, but please don't say this in exam. This again, you should keep it with you that this is one of the technique which is possible in difficult situations, but you will never talk about this in exam. So if there is under dilatation, your treatment will depend on whether there is a guide wire or guide wire is not there. If suppose the guide wire is also come out, then the management is different. If there is guide wire, then over the wire you can again put in a guide rod, put in an amplage dilator, and then reposition the amplage sheath. If there is no guide wire, then you look for where you see the bleeding point. So that is the place probably where your puncture was. And then somebody can put a colored fluid from your ureteric catheter. See if you can see the methylene blue or betadine coming out of three. Once you see from there, try to put a wire from there. If the wire goes in, then again, once the wire is properly positioned, you can put a guide rod, dilate and reposition. Suppose you are unable to put in a wire, then at this place you can go in with a ureteroscope. Under the irrigation of ureteroscope, you will be able to identify this tract, go in, place a wire, and then do rest of the things. So the treatment of a tract loss will be based on whether you have a wire or you don't have a wire. But please do not mention about dilatation by forceps.
See, these are very deadly thing, and it may cause lots of bleeding, and the examiner definitely will not like it. Say
One-
whatever is
Once in
right.
a while, when you are on the verge of the stone, and if stone is seeing just in front, and there is some small tags, that can be dilated, but that may not be told in the exam.
Absolutely, sir.
Correct.
Another
Fine.
important point is parking of the wire is very important. Parking of the wire is always across the PUJ. Try to place the wire across the PUJ right up to the bladder, which will help in placing the antigraft stent. If it is not possible to place across the PUJ, then at least opposite calyx. If you have punctured the upper calyx, it should be parked in the lower calyx or middle calyx. If you have punctured the lower calyx, that should be in the pelvis or upper calyx or middle calyx. And if it is nothing is possible, at least in the pelvis. The OB ने वहां तो कम से कम multiple coils in the desired calyx. So these are the why these are the things to be done is kinking of. Suppose there is kink of the wire, and you can just pull that kink outside the body and negotiate over that kink the guide rod. Or if the wire if the wire is very minimally inside, that can come out, then it will make life difficult. So placing a maximum wire inside the system, and that should be in a place where it cannot be come out easily.
Correct. Best thing is to go across the Pew junction, but many a times you may not be able to do it. Okay. Then, if there is a bleeding, Paras, what you do? You have done the puncture, you have dilated the tract, you go inside and there is a bleeding. Now what you will do?
We can rotate the amplats to stop the
You have
bleeding.
rotated, but now still there is bleeding. You go inside and there is a bleeding.
So
Check the
then,
irrigation.
Pardon?
if there is a uncontrollable bleeding, then we need to stop the procedure. We can keep a, large bore nephrostomy. We can keep a case tamponade nephrostomy tube also, and leave it clamped for 4 to 8 hours, so that the blood clot off in the PCA system and create a tamponade effect, sir.
And the
If
stone is right up to the end of the calyx. You're under dilated, means you are dilated up to the stone. There is no place. Now what you'll do? See, in ideal situation, what you're saying is absolutely right. You just say that whenever there is a bleeding, I will like to abandon the procedure. And the only way to have a tamponade effect is to put the nephrostomy in that place and apply the pressure. Correct? But
See,
suppose if
again,
you are
when you
doing
are
a PC,
answering this question, sorry, sir, आप पहले खत्म करो.
yeah, आप बोलो. I want you to answer.
When you are answering this question, what you should say is, I would want to assess where the bleeding is coming from. Is the bleeding coming from the tract or from the opposite wall? Usually, if the bleeding is coming from the tract, then rotating the implant sheath or taking the implant sheath forward can help. But suppose you have over-dilated and bleeding is coming from the anterior parenchyma, then rotating the implant sheath will not help. Then you should advance the implant sheath in the renal pelvis or across the infundibulum and see whether you can still get clear vision. If you can get clear vision, continue with the procedure. Otherwise, place a nephrostomy tube. This nephrostomy tube should be positioned in a calyx where there is no injury. So usually I would place the nephrostomy tube away from where I've entered, either in the renal pelvis or in the upper calyx. Clamp the nephrostomy tube. You may need to give some compression, hydrate the patient well, keep blood ready, see how patient progresses. Most of the bleeding stop on their own. Once it stops, then after maybe 48 to 72 hours, to the same tract you can come in.
Hello, Gaurang.
हाँ जी,
हाँ,
please.
Sir, boli.
suppose we have done proper puncture, middle posterior calyx or whatever choice of calyx, and on puncture, if you find pus, frank pus or turbid urine, how will you proceed?
See, first of all, when you are doing the catheterization, ureteric catheterization, you will get a pus in such
That
cases.
is, yeah, that is one possibility, but sometimes in a closed calyx, so
Yeah.
the pus may be locked in the calyx only, and it may not come through the ureteric catheter.
Correct. So now, suppose if you are puncture and the pus is coming, only puncture, you have got an option that you want to abandon the procedure, you know. But if there is a closed calyx, and if you want to drain it, then you can just dilate it and just put a small, pigtail or small nephrostomy, so that you can drain it. And next day, after 2 to 3 days, you can go inside and
Yeah.
can remove the stone, or you can do the PCNL. In
Yes.
some cases, if the infection is not like a pus, it is an infected urine. Already you have given good amount of antibiotics and the stone load is not much. In that case, you can go inside. You can remove the full stone, just remove it
Yes.
and put the nephrostomy. But the best thing is drain it,
Abandon.
keep it for some time,
Yeah.
go second time. Otherwise, there are chances that patient may go into
Septicemia.
septicemia.
Yeah.
Yeah. I think in exam we should say that if it is infected, I will like to drain it and go later.
Wherever you see the pus, you abandon the procedure, place
Correct.
the prostam and come out.
Yeah.
And if it is infected hydronephrosis, as sir is described, and if it is under the antibiotic or 4 days together, then it can go inside. We can do a PCNL for small stones, provided that preoperative culture should be either insignificant bacteria or sterile bacteria. Culture should be sterile.
Okay.
At least that will be help in if patient has sepsis, and that will help you in defending yourself in some situations.
Yeah.
Okay. Now, Paras, when you will do what is a tubeless PCNL and when you will do it?
So tubeless PCNL is when we do not keep nephrostomy, and there is a total tubeless where we also do not keep a digestant. For a tubeless PCNL, if the stone load is less, around 2 to 3 centimeter, if we have made a single puncture, there is no residual stone, or there is no bleeding, or there is complete clearance, and we do not require to relook for the surgery in future, and then we can do tubeless PCN.
Asha, you want to say anything?
Yes, sir. In uncomplicated cases,
I would like to go for tubeless PCNL.
Okay, fine. So what he says is that when you are deciding that you are not going to have a second Duke, number one. Number two, there is not much of means there is hardly any bleeding. It is not an infected system. Okay. If there is an infected system earlier and you're done, I will not like to do tubeless. You understand? Suppose
Yes, sir.
there was an infected pyonephrosis or something like that. I have put the digestant or I have done the nephrostomy. I have waited for some time. Then I go inside and I remove the stone. So in that case, I will not like to do tubeless. Third thing is if you think that you damage some part of the kidney, like a pelvis or something, there is a laceration. Again, you will not do tubeless. Okay.
Yes, sir.
Suppose if you have done the PCNL,
Gaurang, एक
yeah,
small, suppose during dilatation accidentally opposite wall is punctured and there is some small perf, and during breaking the stone, some fragments they go out of that this one collecting system. Will you chase them? Will you forget them? Will you just what is your policy?
yes, Paras.
Sir, if the stone are accessible, then we can remove it. Otherwise, we can leave it there. We can explain to the patient about the radio opacity, which can be seen in the later X-ray. Uh, but these stone may cause fibrosis later on.
Yeah.
Yeah. See, if it is a very big stone, small fragments, you don't have to worry. And in such cases, it is better to uh, finish the procedure fast or just
Yeah.
put an nephrostomy and come out. Because when you go after few days, again, it will be easier. Otherwise, there are chances that there may be extravasation of fluid and you may cause more trauma rather than helping the patient. That is number one. And small particles, you just forget about it.
Yes.
Searching and chasing the stone outside the system is not advisable.
Good. Yes, sir.
Fine. So, Paras, you have done PCNL with a nephrostomy and digestion. Now, what you will remove first?
So
See,
first,
both are whatever you say is right, but what is your in your institute what you do and why?
so firstly, we remove the Foley catheter and we watch for the nephrostomy output after the Foley catheter removal. If it is more than 500 ml, then we keep the nephrostomy in place until the output get on the lower side because of the passage of the urine through the digestant. Because of the placement of digestant, when the nephrostomy output decreases, then we remove the nephrostomy. And lastly, after 14 to 21 days, we remove the digestant.
So, in your institute, first you remove the Foley's catheter.
Yes, sir.
Really?
So,
We don't remove. We
no,
remove.
yes, sir. Sorry. So first we remove the nephrostomy and we check for the soakage of the dressing, sir. So
Yes.
if
So normally
it is,
how much time the track will take to close down?
48 hours.
48 to 72 hours.
Normally, suppose you remove by accidentally nephrostomy comes out. Then within how much time if you put an guide wire, it can go easily inside.
It will not go even after just if it is coming out immediately. Also, we cannot easily place it because the parenchyma will fall on itself and the tract may also get closed.
You are
If the
saying 48
distal
hours.
It is not the parenchyma, it is the muscular plane of the tract. Okay, and if the nephrostomy tube is accidentally fallen up or removed within first few days before forming the established tract, then it is very difficult to place the wire immediately after removal of the nephrostomy tube also. But when already it is more than 72 hours, the tract is near to form, थोड़ा बहुत 5-6 घंटे में पहले हो सकता है पॉसिबल अपन वायर डाल सकते हैं, लेकिन ट्रैक फॉर्म हुआ कि नहीं हुआ उसके ऊपर चीज डिपेंड है पूरा.
Yeah. Usually within by 2 to 3 hours, to if there is no other complication, it just closes down. See, most of the so that is why after 2 to 3 hours, if there is no fluid coming from the nephrostomy tract, you can remove the Foley's catheter. So, Paras, why you want to remove Foley's catheter once there is no soakage? Why can't you remove earlier?
so that there is a low pressure system for the urine drainage and there is less reflux.
Yeah, so you want to avoid the reflux, and that otherwise, you know. Now, if the patient says that he is not passing urine for urethra, everything is coming from nephrostomy, why it happens?
So it can be due to the reflux of opposite side urine also through because of the digestion.
One is one cause is overactive
Over
bladder with the, as you are saying, reflux, capillary effect, and everything coming out from the nephrostomy. So what you'll do now?
so we will replace the catheter.
Okay, then
So, and then we'll wait for the nephrostomy output to decrease, sir.
no, it is not decreasing. Now what you'll do?
So, sir, we have to rule out if there is any obstruction in the distal flow of the urine.
And you change the catheter. You are saying, nah, you change the catheter. To decrease the overactivity, what you'll do?
Alpha blocker and bladder
Anticholinergics,
relaxant.
we can-
Yeah, so you'll medical management. Second thing, you can start clamping nephrostomy intermittently and just see that patient is not developing fever or not developing severe pain. And once after clamping, if he starts passing urine from below, then keep the clamp for a longer period of time. And then keep it for 24 hours and see everything is fine. Then you can remove the nephrostomy. Okay.
I don't
Suppose
think
you
use of
removed the
alpha blockers
nephrostomy, you
here.
removed the. Yeah. Bolo, sir.
No. He said he will start alpha blocker with bladder relaxants. I don't think there is any place for alpha blockers.
Clavozet.
You mean
Agreed, sir.
that when the catheter is there, alpha blocker has got no role?
No, sir. For
No.
stent reflux, alpha blocker has no role.
I'm agreeing with Pankaj, sir, because post-operatively, if at all there is a role of alpha blocker, is for the stent-induced symptoms along with anticholinergic in combination. Otherwise, there is no role of alpha blocker.
Yeah, no. Many a times what happens that patient may have sphincteric contraction or he may have some resistance in the outlet. So sometimes little elderly fellow may not be elderly fellow, but even the 45, 50 years old. So there may be a spasm. So in that case, it can be of some help.
Provided that if he is on the alpha blocker or combination treatment for prostate, that can be continued as a post-PCNL. But
Yeah.
selectively for
Only for the reflux neck.
post-PCNL, only for reflux, not otherwise.
So, sir, we were talking about the patient whom you have removed catheter and he is leaking. And when you replace catheter, if you want to reduce the leak, then just bladder laxants are enough. That time alpha blocker is not needed. And as you rightly said, sir, alpha blocker will be given if you feel there is associated bladder outlet obstruction before removal of the catheter.
Yeah. Now, the question was that you have removed the nephrostomy, we have removed Foley's catheter. After 2 or 3 days, now patient comes with the leakage from the nephrostomist side. So Ashay, in this case, what you will do?
Sir, how many days post-op is the patient?
2-3 days. Yeah, everything has gone fine. You have removed the nephrostomy, you have removed the Foley's catheter, patient was passing urine well, and now he has gone away. And now after 3 days, he telephones you, he says that, doctor, I have got some pain, I have got some, fever, and now the fluid is coming from behind.
So, sir, if he is having fever, then I would like to readmit the patient, start him
Yeah,
on IV
no, agree.
antibiotics.
He says little malaise and all these things, and you do WBC count, it is marginally raised. You admit a patient, no problem. I admitted a patient, I started IV fluid, then you'll start antibiotics also, correct? Because
Yes,
one
sir,
of the cause
according
is
to urine
infection.
culture.
Infection
Yes,
can give rise to all these things. Second thing is overactive bladder. Third will be must do X-ray or sonography. X-ray at least to see whether there is any fragment next to the digestant. You understand? There may be some fragment in the ureter that is causing obstruction, and now the urine is coming from the nephrostomy. So what we will do now? Yeah,
sir,
Paras, Ashay.
So we'll restart the antibiotic if
Yeah, you
there is.
start. Yeah, you
Uh,
start antibiotics. Second,
we'll check for X-ray to see if there is any stones or any foreign body in the tract, or the digestant has been migrated. Position of the
yes,
digestant also.
correct.
Uh,
Very good. Then
we can, if the output is larger, sir, then we can replace the Foley catheter. We can
replace the put the Foley's catheter. Patient is
replace
off.
again, replace the Foley catheter.
Yeah, you
Again,
again put the Foley's catheter and start.
and start bladder anticholinergic, sir.
Okay,
To the
fine.
blood.
Then
So,
and if there is a stone, what you will do?
according
if
to the
there's
size of the stone, we can go
Yeah,
for
if it is very big,
ESW or
you might have to go
PAQRS.
inside and remove and put the digestant. Again, if it is a very small fragment, wait for 1 or 2 days. There are chances it will pass out, and then everything will stop. Okay. Now you have done all these things. There is no stone. The digestant is properly placed. You put the Foley's catheter. Everything is fine. Still, there is a leakage. What will come to your mind?
there can be, sir, of infection like tuberculosis or fungal.
Yeah, fungal.
There
Okay.
can be
Atypical
granulate matrix tissue growing in the tract, which is not letting it to
Yeah,
obliterate.
so either there is maybe a foreign body, a small fragment might have left inside the nephrostomy tract, or as you're saying, the infection which is not coming under control, or as you said, fungal infection, or you might have missed, tuberculosis in the kidney, or what else?
nephrocutaneous fistula.
Yeah, but when it happens,
If there is a
either it is
uterine obstruction or
okay. So any ureteric obstruction or infundibulum is blocked. So what you'll do in this?
So we'll relieve the obstruction.
By suppose there is an infundibulum which is blocked. Now what you'll do?
We can dilate the infundibulum. Sir.
How? Earlier we didn't have RIRS. Now you got a RIRS. So what you'll do? You can use the combination, na? Okay, and then after with RIRS you can dilate or you can make the infundibulum little bigger so that everything can be drained very easily. And percutaneously, if possible, you can put the nephrostomy across the infundibulum for some time. Then it will get dilated and the distal part will heal. महेश्वरी जी आपको कुछ कमेंट उसके ऊपर?
नहीं sir, I think fair.
Earlier I had couple of cases, but that time we didn't have this thing RIRS. In one case, it was not a closed infundibulum, but something I don't know what had happened. Lower callus puncture, and it was draining. I had no other option. So what I did non-dependent puncture, PCN, and kept it for some time, and this part healed up. And in a second case, it was like a blocked this thing. So I tried to go through the same calyx again, put under CM guide wire and everything, open up the infundibulum and put the across the nephrostomy.
Nephrostomy across, yes.
Yeah. But this was when RIRS was. I think now if with the RIRS, we should open up the infundibulum, correct?
Absolutely.
Yeah. Okay. So just name the things. Come on. Okay. Why क्यों इतना change? Yeah, tell us what is this? Paras.
So this is a ultra setup for a ultra mini PCNL with a telescope of 3.5 French with an inner sheath and outer sheath. Outer sheath about 11 to 13 French. There are two channel. One is for irrigation and one is for working channel for laser or.
Okay. Fine. And usually which size stone you will like to tackle with this?
Less than 3 centimeters.
For this also?
Yes.
Okay.
What is the channel on the outer sheet used for?
So outer sheath is used for it can be used for suction, sir.
That is mainly used for suction.
Okay.
So again, for UMP, if you have to say, as sir asked, the size should be approximately 2 centimeters, usually for associated secondary stones after the primary tract has been made.
Fine. Paras, just tell all the names.
This is assembly of mini PCNL with mini first there are the dilators with the implant seats. Implants is 15, 16.5 and 21. They are metallic implants with second figure is of mini PCNL scope. It is of 12 French, mostly of wolf. And the lower. Yes, sir.
Yeah. Okay. Asha, you want to add anything? Nothing else more to add, na, to that?
Sir, active alligator forceps is there with the scope in the D.
Now tell me, we have not finished our bleeding point. Now you are done, the PCNL bleeding is still continuing, or the post-operatively patient has got bleeding and he is developing clot retention, hemoglobin is dropping. What you will do?
For CT renal angiography, because
CT,
one
why
of
you
the
want to do CT? Ashay, why you want to do CT?
Sir, the delayed
local.
bleeding can be due to pseudoaneurysm or AV malformation, sir. So we can rule out.
So tell me the difference between two.
So AV malformation is uh, there is abnormal communication between the arteries and the vein at the site of injury, and in pseudoaneurysm there is a rupture of the wall of the vessel which is covered by a clot. When it dislodges, it causes bleeding.
Which are the sites where it will be? So arteriovenous fistula and aneurysm, where they will be?
Mostly, sir, if infundibulum.
What?
Huh?
Aneurysm will be
Infundibulum, sir.
it will be more proximal, na? So where it will be? Before the arterio, then the later on the arteriovenous fistula will form, na? First, you understand what I mean? Pseudoaneurysm is involving only the artery, correct?
Yes, sir.
Paras?
Yes, sir.
And AV malformation is?
Artery and vein. Both.
So, it is more distally, correct?
Okay, sir.
First the artery is
think
there, then the artery and vein comes, na?
I think instead of
Yes.
AV malformation, call it AV fistula only. Don't call it malformation.
Yeah.
Okay, yes.
So what is the treatment?
So it depends ki if patient is stable, hemodynamically stable or unstable. So if the patient is hemodynamically stable, we'll do a CT angiography and we can localize the source for
Why
bleeding.
you
Then
want to do CT angio? I can't understand. Why you want to do CT angio? And if it is showing malformation or AV fistula, what you'll do? Or it is showing pseudoaneurysm, what you'll do?
then we can do a selective
How will you
embolization.
do?
So angiography.
So in digital subtraction, in DSA.
Are? So best thing is to do intervention radiology and do the this thing, na? Arteriogram. Because you can do both the procedure. Through CT scan, how can you do it? If you want to block, you want to put embolization, if you want to do that, how will you do in a CT scan? When you are knowing that there is, you are suspecting this, why you want to do CT? Asha, you like to do 2 times procedure? First, you will do CT, prove yes, there is a AV fistula or there is a aneurysm. Now you take the patient and take him. You already injected so much of dye, contrast. Now you want to do it under Siam.
So
You'll do 2
angiography
procedure
will
or
be
you do 1 procedure.
if we do directly DSA, then it will be diagnostic as well as therapeutic. Better.
Yeah, so immediately take it, no?
combination.
With an idea that you want to. If it is seen, immediately you will block it.
Yes, sir.
Because today, Paras is saying hemodynamically, Arey Baba, today he may be stable, but suddenly he will bleed so much that hemoglobin will drop by 3, 4. He will become pale or she will become pale, and he will not have time also. She may be somewhere in his village where all the facilities are not available. Now what you will do? So in such cases, don't, if you are suspecting there is a repeated Bleeding, first bleeding, yes, you can say that I'll give antibiotics, I'll give, proper hydration, whatever it is, and I'll see that again, second bleeding is not there. And if it is there, immediately you'll do this.
So again,
Fine.
remember that DSA is purely a diagnostic test. DSA does not involve any interventional.
Yeah.
So you will do a conventional angiography and then endovascular treatment of whatever you find in the angiography.
Immediately, I will send the patient for the intervention only and see.
Absolutely, sir. Absolutely. So
Don't
at
waste
best,
time in
if you
such.
want to do, you could do a Doppler to see for the vessels. But otherwise, if there is a serious doubt in this patient, like patient is having repeated anemia, you have given couple of transfusions, there have been couple of clot retentions, then don't waste time, directly get angiography done.
Yes. To be, on other side, for example, it has happened that my patient after 4 days, 5 days, suddenly they come with the bleeding, not a clot retention, but they come with the bleeding. They said there is a bleeding inside, and quite a lot of dark color urine. Of course, we conserve them, give antibiotic, thinking that there may be a secondary, hemorrhage because of infection. So give that, and without any, just this is to tell you, without scientific proof, we give vitamin K, calcium, vitamin K, calcium, all other things, just to satisfy ourselves that I am trying my level best. But that is only once. After that, if patient improves and there is nothing, he is absolutely fine, then you forget. But if more than one bleeding, I think you have to go in, do the intervention.
Remittent bleeding not responding to conservative treatment or active fresh bleeding, straightly shift the patient to the conventional angiography in angiography suite.
Perfect. Suppose it is not stopping, Paras, or you are in a small town where you cannot do angiography. Now what you will do?
So then we need to explore the patient, sir.
And what you will do?
So if we can, it is very difficult to localize the bleeding. If we can localize it, then we can stop it. If we cannot localize it and it is very severe, then nephrectomy should be done.
Okay. So if you localization means what? How you are going to localize? You know that it is bleeding from the puncture site. Correct.
Yes.
Physically, it is bleeding from the puncture site only, na? The major vessel over there only you have injured and it is bleeding. So what you can do? Again, very theoretical. I have not seen anyone.
So we can dissect the hilum and the segmental arteries. We can.
No. Just to take like a purse string stitch on that. Wait whether it is resolving or not. How you do in partial nephrectomy?
Hmm. Yes, sir.
Similar. Just take 2, 3 stitches across and wait. Otherwise, do nephrectomy. If you are in doubt, and other test, always in exam, when the provided the other opposite kidney is absolutely normal,
Normal.
the creatinine is normal, then you'll think of doing nephrectomy when you cannot identify the place from where the bleeding is coming and it is very torrential and
Ex-
it's a question of life and death.
Exploration should be the last resort until and otherwise it is a major vascular injury.
Yes. Other thing is you can identify the place where you can send, you can arrange for the blood, you can arrange for the transport, you can stabilize the patient nicely, go along with him. Important thing is you must go with the patient and with the proper arrangement, get the angiography done. and then embolization. Nowadays, it is possible to reach within few hours. Yeah. Gite sir, or questions? Because
No,
today
sir.
is going to be the last class on instruments. Now only one more class for the pediatric. We are going to request another GRS. सर को बोलेंगे हाँ लास्ट क्लास विल एंड विथ डॉक्टर GRS. So anything, Maheshwari ji?
No, sir. Good.
Fine. I hope they can answer all the most of the questions in exam. And all the students, please, we are going to have a mock exam on 15, 16, 17 in Saifi Hospital by ISU. Correct? Indian School of Urology. Already, I think 110 students have registered. From Mumbai, I don't know how many have registered. So those who are really interested, please register as early as possible, because otherwise we'll have some limitation. And we are going to have one class of about 6 hours on Friday from 2 o'clock to like 10 o'clock, 8 hours only on CA prostate. Dr. Yuvraja is going to, arrange for question answers and the full theory. So please spread this message, and you can contact Sujata, Dr. Sujata, or me also. All these people,
So
Dr.
इसका
Hiren
कोई
will be there as
registration
an
link को तो group
examiner.
में डाल दीजिए सर.
Maheshwari sir will be there. Gite sir will be there. We'll call everyone. Still 1 month is there. Good. So one more class and then we'll stop.
Good.
Okay. Thank you, everyone. Good night.
Good night, sir.
Good night. Good night.
Good night.